So picture this. You are, building this really thriving medical practice.
Right.
You're curing patients. Your schedule is just packed, and you are doing everything entirely by the book.
Doing great.
Exactly. So you decide to expand, maybe bring on a partner, so you formally incorporate your clinic into a group.
Makes sense.
Yeah. But then a month later, your clinic goes functionally bankrupt.
Oh, yeah.
No money is coming in at all. The payroll bounces. And why? Because you checked a box on a web portal to, update your status instead of filing a brand new multi-page application from absolute scratch.
It's brutal.
It is. So welcome to the deep dive. Today we are looking at the invisible, just unforgiving plumbing of the American healthcare system.
And it really is a brutal reality for a lot of practitioners. Providers often assume these administrative systems run on, common sense or basic business logic.
Right, like standard updates.
Exactly. But medical billing actually runs on these incredibly rigid, automated logic gates. Yeah, I mean, a single mismatched identifier doesn't just, delay a payment while someone looks into it. It triggers a total system rejection. You just drop off the map.
That is wild. And that invisible high-stakes infrastructure is exactly what we are tearing apart today.
Let's do it.
We are looking at this really fascinating piece of source material from April 2026. It's an article written by Oliver at Prime Credential, and it's titled, "What Insurance Companies Expect from Group versus Individual Enrollment."
It's a great breakdown.
It really is. So our mission today is to decode this bureaucratic labyrinth. We want to look at the exactitude required just to keep a clinic's lights on when a solo doctor transitions to a group practice.
Which is way harder than it sounds.
Way harder. And for you listening, even if you have absolutely no intention of ever, running a medical clinic, understanding the sheer weight and mechanism of this data entry gives you a completely different perspective.
Oh, absolutely.
Yeah, like what happens behind the scenes after you just swipe your card for a copay.
And the stakes of that data entry, I mean, they really cannot be overstated. We're talking about a system where the concept of a quote-unquote simple administrative update just simply does not exist.
It's a fifth.
Totally.
Yeah.
Every single data point on a claim form is tied to a specific financial contract, and the tolerance for ambiguity is literally zero.
Okay, so before we can understand how a clinic gets its cash flow suddenly turned off, we have to establish how the government and these insurers track who is providing the care versus who is receiving the payment.
Right, the foundations.
Exactly. The source article points to the Centers for Medicare and Medicaid Services, or CMS, as the architect of this system, and they draw a very hard, non-negotiable line between a human being and a corporate entity.
Yes, and that separation is the root of the entire National Provider Identifier System, the NPI.
Okay, break that down for us.
So when a doctor is practicing solo, they utilize individual enrollment. They're built under their own individual employer identification number, or sometimes just, their social security number.
Got it.
And attached to that is a Type 1 NPI. That Type 1 number is a permanent identifier tied directly to that specific human being.
So it's theirs forever.
Exactly. It follows them for their entire career, regardless of where they work.
Okay, so the Type 1 NPI is essentially their permanent medical identity.
Yes.
But the friction starts when that solo practitioner decides to scale up, right?
That's where it all goes wrong.
Yeah, like they hire a few partners, they lease a larger building, and they form a distinct legal entity. At that point, the new clinic gets its own organizational EIN, and crucially, it is issued a Type 2 NPI.
Right, the group NPI.
Right. The clinic is now a group, billing under a single tax ID. But the individual doctors working inside that new building don't suddenly lose their Type 1 NPIs, do they?
They absolutely keep them. And that dual existence is really where the complexity begins.
It's two identities.
Exactly. You now have two distinct identifiers operating simultaneously. The system demands to know the specific human who rendered the service, but it also needs to know the specific corporate entity that holds the financial contract to receive the funds.
Okay, let's ground this in a way that shows the mechanical breakdown of how these two identifiers interact.
Sure.
Think of it like the music industry.
Okay, I like this.
Right. So a Type 1 NPI is a solo artist, like Beyoncé. She has her distinct identity. The Type 2 NPI is the band's LLC, say, Destiny's Child.
Great analogy.
So if Beyoncé performs at a venue as part of Destiny's Child, she is still retaining her individual identity. She's still Beyoncé.
Of course.
But here's the mechanical issue. If Beyoncé's management accidentally sends the venue her personal bank routing number instead of the band's corporate LLC routing number, the venue's legal department is going to freeze the payment entirely.
Because it doesn't match the contract.
Exactly. The performance contract is with the band, but the invoice is asking to pay the individual. The contract doesn't match the invoice, so the money just stops.
And the mechanism in healthcare operates on that exact same principle, but honestly, with even less room for negotiation.
Which is scary.
It is. I mean, the insurance company needs the Type 1 rendering provider to verify the artist who sang the song, so to speak, but they are legally bound to pay the Type 2 billing entity.
Right.
If the invoice gets those crossed, the payer's system simply cannot execute the transaction.
So we have the human being and we have the corporate entity.
Yep.
And knowing the difference between the two seems logical enough. But Oliver's article at Prime Credential points out a massive transition trap that catches countless practices completely off guard.
This is the big one.
Yeah, because when a solo practitioner forms that group, the logical assumption for anyone operating in the modern digital age is that you just log into the insurance payers portal, navigate to your profile, change your status from solo to group, upload your new tax ID, and just go back to seeing patients.
Which is exactly the assumption that leads practices right off a financial cliff.
It's crazy to me.
Well, insurers just do not view this transition as an update to an existing record. They view it as the birth of a completely new legal and financial entity.
So it's not an edit.
Not at all. You are not updating your file. You are starting over from absolute zero.
Wait, starting from zero, even if that specific doctor has been operating in that exact same network, treating those exact same patients for over a decade.
Tenure means absolutely nothing to the automated enrollment systems.
That's wild.
It is. But the transition requires submitting a brand new group application to establish the group EIN, the Type 2 NPI, and the specific taxonomies.
Taxonomies being like the medical codes.
Exactly. The classification codes that dictate exactly what kind of medicine this new entity is authorized to practice.
Okay, I was reading the source's breakdown of specific state rules on this, and the rigidity is staggering.
All the state rules are intense.
Colorado Medicaid, for instance, has a strict policy regarding what they call an individual within a group. A practitioner literally cannot enroll under that status until the overarching group itself is fully approved.
Right, the group has to exist first.
Yeah, so you have clinics trying to hire doctors, but the state refuses to recognize the doctor's affiliation because the clinic's group paperwork is still pending. It is a total bureaucratic catch-22.
And Texas Medicaid operates with similar severity. The source explicitly notes their policy states that changing structures means providers must complete and submit an entirely new enrollment application.
A whole new application.
Yep. There is no bridging mechanism. If a clinic assumes they can just, update their old solo profile and immediately start billing as a group, they enter a state of total limbo.
Because the systems don't talk.
Right. The payers look at the incoming claims, see a billing structure that hasn't been formally vetted, and systematically reject every single one.
See, we really have to look at the timeline of this process because the article mentions this completely new application can come with a 60 to 90-day waiting period.
Easily 3 months.
That's just, in an era where financial technology allows for instant verification, forcing doctors into a 3-month holding pattern just because they incorporated defies basic common sense. Why is the system designed to be this slow?
It definitely feels archaic, but from the insurer side of the table, this is a massive liability check.
Liability for what?
Well, when a group is formed, the insurer is establishing a brand new financial contract with a corporate entity. Paying an individual person involves an entirely different set of tax laws and compliance checks than paying a corporation.
Oh, I see.
Yeah, during that 60 to 90-day window, the insurer is verifying that this new group isn't some fraudulent shell company.
Right, fraud prevention.
Exactly. They're running tax status checks, mapping the specific physical service locations to ensure network adequacy, and verifying the malpractice coverage of the new LLC.
Yeah.
It's a due diligence period, and they just will not rush it.
Okay, so the delay is essentially the vetting process for a new financial birth. So let's follow the timeline forward. The clinic realizes their mistake. They submit the massive new group application, and they sweat out the 90 days.
Assuming they survive it.
Right. But finally, the group is officially approved. The paperwork is finalized. So at this point, they can finally process their claims and let the revenue flow, right?
I would argue that getting approved is merely acquiring the permission to ask for money.
Oh, no.
Yeah, getting the money to actually move requires surviving the physical architecture of the claim form itself, which is a completely different minefield.
And this brings us to the CMS 1500 form.
The dreaded 1500.
Exactly. Whether it is submitted on paper or digitally, this is the standard invoice of the American healthcare system. And the source describes the requirements for this form as a flawless dual NPI dance.
Flawless is the key word. The geography of the CMS 1500 is notoriously unforgiving. The group's Type 2 NTI, the corporate entity, absolutely must be populated in the billing field.
Okay.
On the standard form, that is Box 33A.
So Box 33A dictates where the actual funds are routed?
Precisely. But simultaneously, the individual clinician's Type 1 NPI, the human who actually performed the service, must be populated in the rendering field.
Both have to be there.
If either number is missing, or if a tired medical biller accidentally swaps them, the claim crashes.
Wow.
Yeah, the article highlights Indiana Medicaid to illustrate how aggressively these rules are enforced. They automatically flag claims for rejection with specific error codes like rendering provider not linked to billing group.
Wait, meaning the insurance system acknowledges that the doctor is real and acknowledges that the clinic is real, but because the specific legal linkage wasn't perfectly articulated on that specific form, they just refused to pay.
Yes, that is the electronic data interchange, or EDI, in action.
The EDI.
Right. When a clinic submits a batch of claims, they don't go to a human underwriter sitting at a desk at the insurance company. They go through a clearinghouse.
Which is just a machine.
Exactly. It's essentially a massive software gateway running thousands of automated logic gates. If Box 33A doesn't perfectly match the group NPI affiliated with that rendering provider in the payors database, the clearinghouse kicks the claim back instantly.
No leeway at all.
There is no human grace period. There is no adjuster who looks at the form, realizes the biller made a typo, and processes the payment anyway.
So a mismatch literally equals $0.
Every time.
And the geographic strictness goes even further than just the NPIs, right? Because the Indiana Medicaid example in the source warns that claims will fail at multi-site practices unless you are billing the exact correct NPI and taxonomy code for that specific physical location.
Oh yeah, the location specificity is a massive hurdle for expanding groups.
How so?
Well, if a practice opens a second location across town, that new location often needs its own distinct credentialing. So if a doctor normally works at the North Branch, but covers a shift at the South Branch on a Tuesday, and the billing team submits the claim using the North Branch's location data,
The clearinghouse flags it.
the logic gate shuts down the claim completely. The service provided was legitimate, the patient was covered, but the geographic metadata was mismatched. Claim denied.
It is a system completely devoid of context. It only reads the data syntax.
Yes, it's very literal.
And the article points out a severe timing trap related to this syntax. The group NPI must be active and effective on or before the actual date of service for the claim to be valid.
Which destroys the cash flow of a lot of new clinics.
Because of the 90-day wait.
Right. A practice will often continue to see patients while they were waiting out that 90-day application period for the new group, assuming they can just, stockpile the charts and retroactively bill the insurance companies once the group status is officially approved.
Like a backlog.
Exactly.
But the reality is far more punitive than that. Because if the group NPI wasn't officially active in the payer system on the exact day that patient was sitting in the exam room, retroactive billing under that new group is entirely void.
Totally rejected.
You literally cannot bill an insurer for a date of service that occurred before your legal entity officially existed in their system.
It creates a massive dead zone for revenue. The clearinghouse simply looks at the date of service, compares it to the effective date of the Type 2 NPI, sees the discrepancy, and rejects it.
So they worked for free.
The clinic essentially provided free medical care during that entire waiting period.
Okay, so we have the primary government applications, the 3-month vetting delays, the exact box-by-box perfection required on the EDI clearinghouse logic gates, and the complete lack of retroactive leniency.
That's a lot.
That alone is a staggering administrative burden. But according to Oliver's article, successfully navigating the primary state and federal forms is only half the battle.
Right, because there's more.
Underneath the primary government infrastructure, there is an entirely separate secondary web of private databases that also have to perfectly mirror this new group structure.
And the secondary web is where many practices stumble right at the finish line. Yeah, because the U.S. healthcare system is so heavily privatized and fragmented, insurance companies don't just rely on the government's CMS databases. They rely on centralized third-party credentialing repositories.
Okay.
And the primary one is CAQH, the Council for Affordable Quality Healthcare.
Right. So CAQH acts as a master credentialing file for the private sector.
Yes.
So if a doctor is in network with 5 different major insurance carriers, instead of updating 5 separate proprietary portals every time their information changes, they just update their CAQH profile, and those 5 carriers pull the verified data from that central hub.
That is the intended utility, yes. But the source points out a critical failure point.
What's that?
Clinics will often endure the grueling process of getting their new group approved by the state Medicaid office or Medicare, but they completely forget to log into their CAQH profiles to update the group affiliations section with the practice's new EIN.
Oh, I see.
Yeah.
Which creates an immediate asynchronous data failure.
Yep.
The government knows the doctor is now billing as a group, but the private master file still lists the doctor as a solo act.
Exactly. And when the private payer receives the new claim with the Type 2 group NPI in Box 33A, their automated system pings CAQH to verify the affiliation.
And it mismatches.
CAQH reports back the old solo structure. The clearinghouse sees a data conflict. Immediate denial.
Wow.
Yeah, the source strongly advises making these CAQH updates before a clinic ever attempts to bill a single claim under the new group NPI, just to prevent this cascading failure.
The synchronization has to be completely flawless, and the penalties for failing to maintain this transparency are severe.
Oh, very.
The article brings up Texas rules again, noting they require explicit, immediate notification if a performing provider joins or leaves a group. You cannot just quietly have a colleague cover a shift for a week without formally updating the affiliation matrices.
Right. And failure to provide that immediate notification isn't just a matter of denied claims.
What happened?
Well, if a clinic manages to receive payment without having the proper affiliations accurately mapped across these databases, it triggers devastating audits.
Yikes.
The payers view it as a compliance breach, which can lead to the total termination of the clinic's billing privileges within that network.
Total termination.
Gone.
It is incredible how fragile the entire operation is. Actually,
Yeah.
the company that published this article, Prime Credential, their entire business model exists precisely because this fragmentation is such a nightmare for providers.
Exactly.
They operate as a management service to handle this exact friction, pre-verifying the rosters, managing the EIN setups across state and federal levels, synchronizing the CAQH profiles, and auditing the CMS 1500 forms to catch those dual NPI mismatches before they hit the clearinghouse logic gates.
They do the heavy lifting.
Yeah, they're the administrative shield, so doctors can actually practice medicine instead of managing database architecture.
And when you look at the sheer volume of data entry required to maintain compliance, delegating that architecture becomes less of a luxury and more of a structural necessity for a growing practice.
It really is like the most complicated version of moving to a new house.
What do you mean?
Well, when you move, you fill out a change of address form with the post office and you feel like the job is done.
Right.
But if you forget to separately notify your bank, your credit card company, your employer's payroll department, and your car insurance provider, your life still grinds to an absolute halt.
That's a good point.
Your card gets declined at the gas station because the zip code on the terminal doesn't match the outdated zip code in the bank's database, even though the post office knows exactly where you live.
And CAQH is the bank in this scenario.
Exactly. In healthcare credentialing, CAQH and the individual payer portals are those critical secondary updates. If you only tell CMS that you formed a group, your claims are still going to be declined at the terminal.
The ecosystem is deeply interconnected, yet entirely asynchronous. It demands absolute consistency across platforms that do not automatically communicate with one another.
We have covered a massive amount of systemic ground today. We started by defining the fundamental difference between the solo Type 1 NPI human and the organizational Type 2 NPI corporate entity.
Right, the Beyoncé versus Destiny's Child.
Exactly. We exposed the myth of the simple profile update, detailing why forming a group requires enduring a brand new application and a 90-day vetting process.
Bad zone.
We broke down the unforgiving mechanics of the claim form itself, where a single misplaced number in Box 33A triggers an automated clearinghouse denial.
$0.
And finally, we looked at the necessity of synchronizing all of this across secondary databases like CAQH to avoid audits and network termination.
The level of vigilance required to navigate this transition without bankrupting a clinic is staggering. It is a highly specialized administrative discipline that operates entirely out of sight of the average patient.
And for you listening, that is the core takeaway of this deep dive. The next time you are sitting in a clinic waiting room, thumbing through your phone, and you look over at the front desk staff, you should have a completely new appreciation for the high-stakes bureaucratic acrobatics happening on those monitors.
They're doing so much more than scheduling.
Way more. They are not just typing your name into a calendar, they are actively maintaining a highly fragile architecture of tax IDs, taxonomy codes, and dual NPIs just to ensure the clinic actually gets paid for your 15-minute consultation.
They're the ones keeping the machinery from collapsing.
Truly. Now, we have spent this entire deep dive looking at how fragile and unforgiving this system is. The 90-day waits, the absolute lack of retroactive leniency, the automated clearinghouses that deny a claim over a single misaligned taxonomy code.
The friction is immense.
It is. But stepping back from the mechanics, you have to wonder about the intent behind the architecture.
What do you mean?
Well, is this staggering zero-tolerance complexity simply the unavoidable necessary byproduct of trying to prevent fraud and maintain order in a multi-trillion-dollar healthcare system?
That's the official line.
Right. Or could this bureaucratic maze be a deliberate friction point? A system highly optimized by the insurance industry to systematically reject claims, delay approvals, and hold on to their capital just a little bit longer.
Oh, that's a serious question. When the automated logic gates are designed to default to $0 at the slightest syntax error, the line between necessary fraud prevention and intentional financial friction becomes incredibly blurred.
It brings us right back to the plumbing hidden behind the wall. We all just want the water to run clear when we turn the handle, but the mechanics controlling the flow are infinitely more complicated and perhaps far more intentional than we ever realized. Thank you for taking this deep dive with us. Keep questioning the systems operating behind the scenes, and we will catch you on the next one.